From Microbe TV, this is TWiP, This Week in Parasitism, episode 247, recorded on November 1st, 2024. I'm Vincent Racaniello, and you're listening to the podcast all about parasites. Joining me today from New York, Daniel Griffin.
Hello, everyone.
What's on your bow tie? Parasites Without Borders?
It's a little bit of a hint for people that are trying to figure out this tricky case.
Oh my gosh, you just gave it away.
Yeah, you're too easy. You really are.
Daniel, today is a Friday.
We'll see.
Today is Friday, so you're wearing the right bow tie.
It
right?
is a sexually transmitted pathogen. Yeah.
Wow.
That's true.
Also joining us from Fort Lee, New Jersey, Dixon Despommier.
Hey, Vincent, Daniel, and Christina, or Christina, Daniel, and whatever. It's a regrettably beautiful day on November 1st in my neighborhood.
Dixon, I'm going to start believing in this global warming,
I think you better.
Pseudoscience stuff you keep talking about.
Pseudoscience stuff. Just believe your eyes, not your ears, and you'll be fine.
Also joining us from Glasgow, Scotland, Christina Nowla.
Hello, good to see you all. I'm sorry I missed the last episode, but it's good to be back.
How is it there in Glasgow? You got darkness?
Good to have
you. Oh, it's really dark. It's a bit earlier than usual because we've turned our clocks back already. I went out for a walk and we have what we call smur. And it's kind of drizzle that never really precipitates and you can't feel it, but you come in and you're completely soaking wet. So that's the kind of weather we had this evening.
Is it?
Wow.
Oh, okay.
Now, is it cold or is it hot there in Scotland?
It's quite cold,
yeah.
Okay. I don't know the temperature, probably below 10 centigrade. Sorry?
There was believing in global warming, and now I've got a little bit of just,
It's a nice day here in the New York area, isn't it, Daniel?
Oh, I'm a bit jealous.
It's over 80 degrees. I went for a run earlier today and I was actually hot. I was like, oh my God.
Wow.
I was really running slowly and I'm blaming it on the heat. But
well,
I just turned the heating up in my house so I wouldn't be too cold.
Oh, wow.
If you enjoy these science programs from Microbe TV, we'd love to have your support, your financial support, because that's how we do them. We don't have advertisements. We have donors like you. So if you would like to contribute, actually now, Parasites Without Borders is doing their end-of-year Microbe TV fundraiser. So if you go over to parasiteswithoutborders.com and click the donate button, you make a donation there, it'll go to Microbe TV, but they will double it. Up to $1 million.
I think it's only up to 20,000, Vincent. But
sorry, I got the decimals. I got the decimals wrong. But if you want your money to go farther, you go to Parasites Without Border for November, December, and January. Okay, we'd appreciate your support. Today is time for cracking a case and pulling up a new one. So, Daniel, what do we have here?
All right. Well, I was hoping this would be an easy one because I will tell you ahead of time, the next one is very complex. So this is going to give you guys just a little bit of a chance to, feel good about yourselves and feel like you're expert parasitologists. I hope. We'll have to see what the emails come in as. And then I will lay a much more challenging one on y'all. So we'll start off with the case from our last episode. For those of you tuning in, those of you tuning back in, presented the case of a man in his early 20s who comes in reporting pain when he urinates or ejaculates. I want people to tell me why. Why does it hurt when he ejaculates? He reports that he is sexually active, and he does confide that he's been in a relationship with a woman, but he had a sexual encounter outside this relationship about 2 weeks prior to this medical visit when they were, as he says, on a break and he did not wear protection. He feels like he needs to urinate more often and describes thin white discharge from the penis. He reports that he has no history of any sexually transmitted infections prior to what may be one here. No medical issues, HIV negative, otherwise had been a healthy young man.
Okay, we had some good number of guesses. And Dixon, can you start off with that first one?
I'd be happy to do so. Hakon writes, greetings and thanks for another fun case. My guess for the next week's case is Trichomonas vaginalis, given the symptoms described. Nothing else really comes to mind as specifically as an STI transmission here. I suppose if he went swimming in the Amazon, he might have attracted a candiru. That's a small catfish, by the way. But this seems extremely unlikely given our history and completely ignore the STI part of the case. Hoping it clears up quickly for our poor John Doe. Thanks, Hakon.
So, Dixon, this candiru is a small fish?
It's a small teleost of the catfish genera, and it's small enough to fit through the urethra. And it's got fins that point back along the body, so it can go in, but regrettably, it cannot come back out again. So it requires
how would it get in there, Dixon?
Manipulation. They swim in. They follow a trail of urea.
So don't pee in the water when you go swimming in the Amazon.
Are you kidding? No, just wear your knickers.
I just can't imagine how someone could be so clueless to allow a fish to swim up the urethra. I just don't get this.
It's about a 16th of an inch in width.
Look it up. I was going to say that too. I think it. I mean, you will find this, fact or fiction, urethra invading candiru fish. So I'm not sure if it's real.
You're not buying it?
I don't buy it.
You don't buy it? You don't buy that? I will send you some proof.
Here's the reason, Dixon.
They've actually surgically had to remove this.
Normally.
Tell me why.
Dixon, normally, so the end of the urethra is called the meatus, right? The opening. Normally, that's closed, right?
Yeah.
So if this fish wants to get in, it's going to have to start prying around, and you're going to feel that, man, because it's pretty sensitive down there, and you're going to swat it away. I just don't believe this.
And they're
I'm gonna say so. I will. I'm gonna read this AI generated response. And so here's what they say. They say there is little credible evidence that the Kandura fish has ever invaded a human urethra. The first documented case of a Kandura being removed from a human urethra was 1997, and the account was controversial. Some say that the evidence for Kandura attacks comes from 19th and 20th centuries explorers, and that the reports were likely based on speculation and hysteria. And Vincent, as you point out, here are the issues. So size. The Kandura is actually not small enough to fit in the human urethra, right? So there's a size issue. And the next is the Kandura detects fish by sight, not sense. This whole urethra trail, that's just they
it's not a urethra trail, it's a urea trail.
Don't worry, I got two more.
Okay.
The other is there's actually this fluid dynamics issue where the physics of fluid dynamics actually don't make it possible for the Kandura to swim upstream with a flow of urine. Yeah. All right. So
yeah,
I actually just found a systematic review on that as well that was properly published and not AI generated.
Okay.
And their conclusions were, until evidence of the fish threats to humans is forthcoming, there appears to be no need for considering the Candiru in health advice for travelers to the Amazon. And that's been published in the Journal of Travel Medicine, a while ago in 2013. But, so how did we get there?
Yeah. Well, no, the emailer was.
Oh, yes, that's right.
It was in the differential, and we're going to suggest that.
Yeah, we appreciate Huck, and we appreciate the opportunity to talk about this. I think that's very interesting. But yeah, I think it's unlikely. Okay, Christina, can you take the next one, please?
Yes, I can. Fritjof writes, greetings from Botucatu, Brazil. And, going back to the Amazon, aren't we? The young man presenting with lower urinary tract symptoms after an unprotected sexual encounter probably suffers from trichomoniasis. The most important non-parasitic differential would be gonorrhea. He should be tested for other STIs such as chlamydia and syphilis, and an HIV test should be offered. Furthermore, his current partner, not on a break anymore, should be tested, and if necessary, both of them treated with metronidazole. Thank you for your amazing podcast.
Not on a break, huh? Daniel.
All right. Jason writes, Dear greetings, TWiP hosts. In episode number 245's case of the Manhattan Mastigophora mystery malady, the patient appears to be infected with Trichomonas vaginalis. This sexually transmitted infection usually occurs asymptomatically in males, but in this case, the patient's presentation is consistent with symptomatic trichomoniasis. In the presence of T. vaginalis, flagellated protozoa is confirmed to be a culture of urine or urethral swabs. The patient should receive a single oral dose of 2 grams of metronidazole and an admonishment to wear a condom during future sexual encounters. Warm regards, Jason, Seattle.
Dixon, do you know what a mastigophora is?
All of the flagellated protozoans fall into the group Mastigophora, and that includes the trypanosomes, the leishmanias, and this particular entity that we'll discuss. Not Candura. Candura is totally different. No flagella whatsoever.
Okay, Michelle and Alexander from the First Vienna Parasitology Passion Club write, Dear tricksters of parasitology, the patient from this month's case is probably infected with Trichomonal vaginalis. The parasites are detected via microscopy of secretions. However, we would like to take a more thorough sexual history in this case in order to provide optimal care. To determine his risk of acquiring other sexually transmitted infections and to counsel him about sexual health, we would inquire about the following points. Partners. We would ask about the number of partners he's had in general and within the last months. We would then ask what our patient knows about them in terms of risk factors, HIV status, number of partners, intravenous drug use, etc. Does he have anonymous partners? What is the anatomy of his partners, or rather, what gender are his partners or partner? While inclusive language is important, we often have to simplify in order to maintain clarity of communication. Practices. What kinds of sex is he having? I.e., which body parts are involved and how? For example, does he have penetrative vaginal sex? Does he have receptive anal sex? Does he participate in chem sex? I have no idea what chem sex is.
Stop right
I guess
there.
you take drugs and you...
Daniel, you'll have to explain this.
Yeah, I will say I don't know what chem sex is. Christina,
I've never
do you
heard
have
of
any?
it.
I'll
No,
Google
I'm afraid
that
I
while
have
you
no
talk,
idea.
and then
You have sex.
I'll bring us all up to speed.
Do you want to Google it? It might bring up some not.
Yeah, crystal meth and other stuff. Yeah.
Chem sex.
Party and play.
All right. Protection. Does he consistently use condoms? Is he on PrEP for HIV? Is he on Doxy PrEP? Has he required PEP recently? Has he been vaccinated against hepatitis, HPV, Mpox, or meningococcal disease? Prior STIs, does he know his HIV status? Has he ever had an STI? Has he ever been screened for an STI? Bonus, offer PrEP. We would like to educate him about HIV PrEP. If he's interested, we would offer him oral PrEP or perhaps injectable PrEP, depending on external circumstances, in order to prevent HIV infection in the future. Before treating his trichomoniasis with 2 grams of oral metronidazole, assuming he is cisgender, we would like to screen him for other STIs. We would start with a physical exam, looking for signs of inflammation around his genitals, lymphadenopathy, condylomata, and other skin findings. We would also send a urine sample for PCI for Neisseria, chlamydia, and ureaplasma, and do the same from a self-collected rectal swab and a provider-collected throat swab if these body parts were involved in sexual contact. We would also send serology for HIV and syphilis. Lastly, we would ask him to get both his partner and his last sexual contact to come in and get tested for trichomonas and other STIs. Failing this, we would recommend expedited partner treatment with metronidazole, 500 milligrams twice daily for 7 days, assuming they are cisgender. Thank you for this great case. All the best, Michelle and Alexander from the First Vienna Parasitology Passion Club. So, Daniel, let's remember to come back and explain why being cisgender makes a difference in the treatment, okay?
Yeah, there's a lot in here. We'll definitely circle back to this this email, dig through it.
Okay. So now we're back to Dixon. Can you take the next one?
Justin writes, "Hello, TWiP hosts. Happy fall to all, and hoping you have lovely weather wherever you are," and we are. For the case of a sexually transmitted parasite from TWiP 245, my guess is trichomoniasis. There really aren't many options to pick from when it comes to sexually transmitted parasites, which helps narrow down the field. I wonder why this is. There must be some reason bacteria and viruses have so much more success in this route of transmission. Thanks, as always, for a great podcast, Justin.
Christina.
Ronan writes, "Afternoon TWiP team. First time writing in. I'm studying on the DTMH in London in the UK, and we've been discussing your cases on the course. Lots of TWiP fans here. I think this is a case of trichomoniasis, the Ne plus ultra of venereal parasites. It sounds like you made a diagnosis in the clinic with a wet smear and maybe one of the new Trichomonas rapid antigen tests instead of needing to wait for culture. Management-wise, this patient needs 2 grams of metronidazole as well as a HIV test, especially given the increased risk of HIV infection in patients with trichomoniasis, as well as a syphilis test and STI co-infection screen, as well as partner notification, screening and treatment. Thanks for the great podcast, Ronan."
John writes, "Greetings, hosts. My guess for the case is Trichomonas vaginalis. The clear whitish discharge and itching while urinating are common signs of T. vaginalis, as well as needing to urinate more frequently. The parasite can be diagnosed by microscope, so that diagnosis and treatment can be done on site, which was already mentioned. Thank you so much for the great podcast."
Ann writes, "Hi, TWiP team. My guess for the case of the young man with urethritis is Trichomonas vaginalis. The majority of sexually transmitted causes of urethritis are bacterial and viral, so the choice for parasitic pathogens is somewhat limited. I love the most recent episode of veterinary screwworm infection, which I completely missed. I'm a listener old enough, experienced enough to have been taught about screwworm infection in veterinary school, Texas A&M 1986. So was chagrined to have missed the diagnosis. Still hoping to win a book. Regards, Ann." Dixon.
John writes, "Still hoping to win a book, and I missed the deadline, but who knows? Doesn't hurt to try to sneak it in. Trichomonas vaginalis is a protozoan that can be sexually transmitted, and increased risk are associated with unprotected sex and multiple partners in the time frame mentioned here. Previous infection does not confer immunity, so after treatment, reinfection can occur and is common. The patient reported dysuria, white discharge, and Dr. Griffin reported he was able to diagnose after microscopy, which all tracks with this diagnosis. Treatment can be metronidazole, often given as a 7-day course at 5 milligrams twice a day, or as a vaginal gel. Reinfection is likely if sexual partner is not treated concurrently. So I imagine that was suspected. Dr. Griffin recommended it. The use of condoms during sexual intercourse and limiting the number of sexual partners will decrease the risk of infection. John.
Christina.
Colorado State University's Uncultured Microbe Society writes, "Hello, TWiP team. Greetings from Colorado. The weather today was quite cold. In fact, we had our first snow. It is crazy to think about how fast this year is going by. Regarding the case mentioned in TWiP 245, we believe that the parasite responsible is Trichomonas vaginalis. This protozoan parasite is transmitted sexually, partner to partner. There are many different ways to test for this parasite. Some methods we considered included PCR, swabbing the urethra and examining the fluid, or using an ELISA. For treatment, we prescribe either metronidazole or tinidazole. It is also important to consider treating both of the man's partners, as they may have had the parasite spread to them. Along these lines, it is common for reinfection to occur from partner, so by treating everyone involved, this is prevented. Anyhow, we look forward to hearing the answer to the case, and we wish you all a happy November. Sincerely, the Colorado State University's Uncultured Microbe Society. Like that name.
All right. Galen writes, I didn't know Galen was still alive, but exciting. Hello, doctors. I'm afraid I missed the deadline. I'll give it a go. I think this gentleman has a Trichomonas vaginalis infection. A course of metronidazole should take care of him. It's a fun one to see under the microscope and satisfying to make the diagnosis then and there. Thanks, Galen.
Ayana writes, "Hello, professors. I'm writing to you from sunny Trinidad. This 20-year-old male presenting to the clinic in New York with dysuria and penile discharge could possibly be suffering with trichomoniasis caused by Trichomonas vaginalis. Though normally described in women, this infection can cause penile discharge in males associated with dysuria. Protozoa can be seen if the discharge is viewed under a microscope via a wet mount technique. Sample can also be sent for culture and molecular diagnostics as other options. He would benefit from treatment with metronidazole for 7 days. Consideration should also be given to testing and treating his partners. I hope I'm not too late to submit. Looking forward to the discussion." And I'll do it for our guesses.
All right. Well, we've got 3 more guesses, and I was actually hoping from you 3 experts to get a little more detail. The pathogen, and I want to know why was it painful with ejaculation? So, anyone wants to jump on in?
Well, jumping is hardly the expression I would use, but let's just say I have a few added comments. Now, the first one is that there are some interesting biologies going on here. It's an obligate, first of all, Trichomonas is an obligate anaerobe, and it possesses an unusual inclusion in its cytoplasm, and it's called the hydrogenosome. And the hydrogenosome actually generates molecular hydrogen. Now, are you listening, energy experts out there? It would be interesting if we could harness the hydrogenosome, apart from Trichomonas, of course, to serve as a clean source of hydrogen for the future hydrogen fuel cells that we're about to initiate upon the world. Now, back to the pathogen. The pathogenicity of Trichomonas is not solely due to the presence of the organism itself, but it also has included into its cytoplasm an infection of its own in the form of a double-stranded RNA virus. And that double-stranded RNA virus is associated with increased inflammation in women who have this infection.
All right, so you're going with trichomoniasis.
Oh, I am trichomoniasis.
But why does it hurt when he ejaculates, right?
Why does it hurt when he
ejaculates? Do you have any?
Well, it's obvious that he's got a rash caused by the protozoan, which extends down the entire length of the penis to the glands responsible for composition of the semen that they produce. Otherwise, he wouldn't be in any pain at all. And by the way, most men with this infection are not in a lot of pain to begin with. So it's unusual to find somebody who's exhibiting symptoms that's not female. Vincent, any comment you want to make about the toll-like receptors and trichomoniasis with regards to the double-stranded RNA virus?
Yes. So these parasites.
Remember, we reviewed a paper on that.
Yeah. We did a paper. These parasites are infected with a virus, the T. vaginalis virus, and the presence of the virus exacerbates the disease.
Yes.
And the reason is that the virus has double-stranded RNA, and that's sensed by toll-like receptors, which causes inflammation. So you get heightened inflammation above what you would get with just the parasite, and so it makes the infection worse. Yeah.
There you go. Right.
All right. And what are you thinking, Christine? Are you on the same page?
Yeah, I'm also on Team Trichomonas, and really the only other two parasites I could think can be sexually transmitted are ectoparasites. I think I'm going to go for Trichomonas as well. And I'm not sure about the ejaculation, Daniel, but I thought maybe Trichomonas can maybe cause inflammation of the epididymis and the epididymis, that one,
Epididymis.
and the prostate. So maybe
See, you
that
could always pronounce
cause
it any way you want and claim that that's the Scottish pronunciation.
All right, yeah, I could do that. Yeah. So I don't know. I mean, that's the only thought I had, because it can be causing inflammation in those glands as well. I don't know. I'd be really curious to find out.
Okay.
It's not a parasite I often think about. We do have some beautiful slides in the lab. They are beautiful to look at. We can see them on your tie as well, I think.
There is another mastigophorine that is transmitted sexually, and it's a parasite of horses, as I recall, and it's a Trypanosoma equiperdum.
Yes. Sorry, I was only thinking of humans. I just read about that today, actually. I'd forgotten. Sura is the disease that's causing.
Right. And it's responsible for abortion in female horses, of course.
I forgot about that one. I was just considering people in my anthropocentric kind of world.
Can't blame you at all.
I have to recount some experience. When I was, after I graduated college, I worked for a pharmaceutical company, and one of its products was a trichomonocidal product. Okay. And so it was my job to test the potency of the product. And so I cultured Trichomonas vaginalis in the lab. And I looked at it under the microscope and saw the cool things with flagella moving around. And then I would add the trichomonocidal thing and watch them die. So that was my experience with trichomonas.
Wow. Are they easy to culture, Vincent?
You need anaerobic conditions, right? But we were able to do it. I don't know why.
The right temperature.
The gentleman I was associated with at Rockefeller, Miklos Mueller, was a world expert on trichomoniasis. And his culture system was extremely clumsy, I would call it. It took up a lot of space. And there was a hood that he had to work under with rubber gloves. And the whole atmosphere inside, of course, was without oxygen. Otherwise, they would not survive. And he discovered a lot of things about the organism after he learned how to culture them. But did you know Miklos while you were at the pharmaceutical company?
No, I didn't.
Okay. Because he was the one who discovered the hydrogenosome as well. No. No. That doesn't get rid of all the oxygen anyway.
Didn't Traeger do that for malaria?
He did, but it's because Plasmodium falciparum is a micro-aerophil.
Okay.
It's not a strict
got it.
Anaerobe.
So let's go through. So first off, yes, this was what was suspected, the Trichomonas vaginalis, and so the diagnosis was actually made by taking a swab and then putting this into some saline and then looking at that under the microscope. And it's really interesting if you get a chance to do this. There really aren't as many microscopes as there should be in clinical practice.
I agree.
But if you immediately take that saline and look at it, like right away within the first minute, you will see these beautiful flagellated organisms swimming all about. But really, you lose about 10% of them per minute over about 10 minutes. So it really has to be a point of care test. Now, a lot of times now people are using these molecular tests. So that was number one. So number one was the diagnosis of trichomoniasis was confirmed. The second, and this was something that was brought up, I'll give you guys both credit, Dixon and Christina, is that trichomonas doesn't necessarily restrict itself to the urethra, but actually can invade all the way down into the prostate and the epididymis. And so in this case, this gentleman actually had tender epididymitis from this active infection with trich. And so that was, when you sort of got a little bit more is when you ejaculate, where does it hurt? And it was actually down like in the prostate, in the epididymis areas. Also, as some of our folks suggested, we talked a little bit about other testing, right? Because, Occam was not a doctor. Hickam was. You could have more than one thing, particularly in this arena, right? So you want to, you want to test, as we did for HIV, for gonorrhea, for chlamydia, for syphilis, right? You want to go through looking for other sexually transmitted infections. And then the other thing that he brings up, and actually, Dixon, you brought this up because that was the teaching that I was taught in medical school, was that women are symptomatic, men are not symptomatic. So that came from a study where they actually tested partners and found a number of sexual partners of infected women tested positive. 75% of them had no symptoms. So then someone was really smart and they said, why don't we screen a whole bunch of women, do it the other way? What percent of women test positive but are asymptomatic? 86%. Right.
Wow.
So this is actually predominantly an asymptomatic disease in both men and women. And so this is really why we encourage people, who take care of individuals that are sexually active to, not just sort of stereotype your patients, but actually go ahead and test them, because that's the only way to find out. Because a lot of these sexually transmitted infections can actually be asymptomatic.
Is this a exclusively human infection? So do humans always get it from humans and we're the only reservoir?
The answer is yes. And there is no cyst stage to this as well. So it's a trophozoite infection that's spread by trophozoites and not by a cyst like for other protozoans that might have an environmentally resistant stage that it can survive outside the host with. So if someone says they caught it from a toilet seat, the answer to that is, and who else was on it with you? Rather than, because there's one major exception to that, by the way, and that is apparently young girls that are born with mothers that are infected can become infected, and they can grow up with asymptomatic infections for a long time, and sometimes they spend their whole lives without knowing that they have it. But that's not common. I don't know, Daniel, you got any more information on that?
Fortunately not common, but I think that really is the right question. Who else was sitting on that toilet seat with you if you end up with this infection?
Or how many others were sitting on
that? Maybe the toilet seat thing is chemsex.
Possible, but
yeah.
No, I'm just joking. Chemsex is when you take drugs and then you have sex.
Okay, so some of the other things that came up. Yes, condoms, right? Barrier condoms would be a great way to protect yourself from getting this and a lot of other things. And that's actually a challenge right now that people are using PrEP, pre-exposure prophylaxis for HIV, because as I always have to counsel these individuals when we see them on a certain cadence, is that the pre-exposure chem prophylaxis, right, being on these medicines, can protect you from getting HIV, but it doesn't necessarily prevent you from getting a lot of these other sexually transmitted infections.
That's exactly right.
And with HIV, there's PrEP. There's also a PEP, a post-exposure prophylaxis, and there's also a PIP, a pill in pocket. Now, Doxy has recently been introduced really more as a PEP. It's a post-exposure, right? This is, you have a sexual encounter, not protected, and then take doxycycline after the fact, right? And that's being rolled out. A little bit of concern because we're already seeing doxy resistance.
That's right.
in the STIs. And then, of course, now that's being introduced into a social network where that's being given out. So I do worry about the implication there. The other is this issue of cis versus transgender, right? So cisgender is, basically your XX and you identify as female, your XY and you identify as male, right? So that would be cis. And there is a difference, it's evidence-based recommendation as far as treatment. So in general, for a cis male XY, this 2-gram metronidazole single dose is the recommendation. With a metronidazole 500 milligrams BID times 7 days as an alternative. It's actually flipped in cis females, XX, where it's 500 milligrams twice a day times 7 days as your preferred, and then the 2 grams oral metronidazole as alternative. But then there's also this issue of expedited partner treatment, EPT. And this is this issue where, in this case, for this gentleman, he went ahead and he got himself this infection. Not only do you want to treat him, but you want to make sure the partner gets the benefit of treatment too. Otherwise, one, they might go untreated. As mentioned, 70, 80% of these folks are asymptomatic, whether it's male or female. And it can basically bounce back and forth between the two of them.
You would treat based on sex, like XX or XY, not gender.
Yeah, so it's not your gender identity, it's the biology. And the only reason we're saying that is those are the studies were done. The studies were done in XX individuals, XY individuals. But in all honesty, and we'll often do this in EPT therapy, is we'll go ahead and we'll just, you get 2 grams, your partner gets 2 grams. We do it right there before they leave the clinic just to make sure it happens. But what Dixon is bringing up is that we do have metronidazole resistant Giardia and trichomoniasis. So we're seeing resistance. And actually in parts of the US that can be as high as 10% for trichomoniasis. Wow. So, if we do a 2 gram and we fail, sometimes we'll use tinidazole, we'll sort of retreat. The others, you want to be careful because a lot of people are using molecular testing and the symptoms can continue. So you don't want to repeat a molecular test within 3 weeks because it's going to stay positive, right? It's like some of those Mary's tests, right? I mean, maybe people have learned that a positive test doesn't mean the organism is still viable. And sometimes when you fail, you actually have to reach out and work with the CDC, and we get paromomycin and some other therapies. So that's all I got. That's
time to give away a book.
That's all you got.
All right, time to give away a book. Let's give away a book.
Yes.
We have 11 guesses.
I'm not sure I can go that long. How many? Okay, here we go. You ready?
I'm ready. Go ahead. Number 6. Our winner is number 6, who is John. John is the winner. So, John, send us your address. You send an email to TWiP@microbe.tv. In the subject line, you say TWiP 247 book winner. and just send us your address. If you're living out of the U.S., then you should also send a phone number. The Postal Service requires that. But if you're in the U.S., a address alone will do, a postal address. And once again, email twip@microbe.tv, subject line TWiP 247 book winner. Thank you, John.
Nice.
All right. So are we on to our hero now, Christina?
I think we might be, yes. It was actually really nice to prepare a hero because I haven't done one for a while. So today I wanted really to celebrate a Nobel Prize winning parasitologist because there's not that many of them. And the ones that have won Nobel Prize that we've already discussed as heroes, but I found one that we haven't mentioned yet in our hero series. So this is Charles-Louis Alphonse Laveran. I'm trying my best French here, but I'll probably stick to the English pronunciation. And I will also call him Alphonse Laveran because that seems to be the preferred name that is often mentioned. So I'm actually reminded of this scientist every time I look down at a Plasmodium falciparum blood smear. And I spot a gametocyte. And for those you know, but I have copied an image onto our show notes, so just to illustrate what I mean, because sometimes in gametocytes of Plasmodium falciparum, you can see the remnants of the host red blood cell, and it kind of looks a bit ghostly, but that structure is referred to as the Laveran's bib. So that was a reason for choosing this gentleman, although obviously he's done a lot more important things than just naming that dead red blood cells remnant. So I found most of the information about these heroes on the Nobel Prize page for Alphonse Laveran, and I've put the link for that in the show notes as well, so you can read up on that a lot more, and you can also read his conference or his acceptance speech, which is quite interesting to read actually. So Laveran, he was born into a medical family in Paris in June in 1845, and both his father and grandfather, they were doctors. He spent some time in Algeria with his family, but he was primarily schooled in France. And I don't really have much information about his childhood, which is a shame because I think sometimes knowing a bit more about someone's upbringing and childhood interests is really quite informative, and maybe gives us clues about someone's life choices. But it is probably safe to assume that Alphonse's career was influenced by his father's own career as an army doctor. So he studied public health, or he was studying at the public health school in Strasbourg in France from 1963. And then he was appointed as a medical resident in Strasbourg in public hospitals, where he kind of was working or interested in nerve in regeneration of nerves. So that was the dissertation that he chose to focus on during his residency. I don't know, do you do dissertations in the residencies here in the medical education? I don't know, it's something I've not heard before.
We usually don't. No,
yeah, I've not heard that either. Should probably have skipped it. Anyway, so then in 1870, the Franco-Prussian War broke out, and he was a medical assistant major, and he served in the army in Metz as an ambulance officer. And just a little history lessons in here, because that Franco-Prussian War is actually really important for European history. So it was a conflict between the Second French Empire, so the empire after the French Revolution, and the North German Confederation that was led by the Kingdom of Prussia. And that war had a really lasting impact on Europe. For example, it led to the German unification, or it sped it up a little bit. And it also changed the balance of power in Europe quite significantly, with Germany replacing France as the new dominant European power. So I thought that was quite interesting as well. But it's not this week in European history, so I'm going to return to Alphonse Laveran again. So after the war, he practiced medicine in Lille first and then in Paris. And he was appointed the chair of the military diseases and epidemics at the École de Val-de-Grâce, which I don't know where it was, in 1874. But this was also where his father had previously worked, and the same post that his father had held. So he was then deployed to Algeria a few years later, and he spent 5 years there. And it was really during that time when he carried out his important work on human malaria parasites. He also visited Rome. He analysed bloods of local malaria patients there, because malaria was still very common in Europe at this time. And so this work in Rome really convinced him that the blood parasites of the Plasmodium family he had also described in Algeria were in fact the cause of malaria. And this was a finding that was at first received with some skepticism, but they were eventually confirmed independently. And he was also awarded a prize for his discovery by the Academy of Sciences in France. So he then worked for about 10 years between 1884 and 1894 as a professor of military hygiene at the École de Val-de-Grâce. And then he was first chief and then principal medical officer, and then the director of health services of an army course in Nantes in France. And he didn't really have any patients, but he continues to kind of maintain his interest in his scientific parasitic investigations. And then in 1897, he held a position at the Pasteur Institute. And that's really where he did probably the majority of his parasitic investigations, and including on Plasmodium and also trypanosomes. So in 1907, he was awarded the Nobel Prize in recognition of his work on the role played by protozoan parasites in causing diseases. So he was the only prize holder that year, which I think is quite unusual now. You would often have multiple Nobel Prize holders in any given year. He donated half his prize money to the Pasteur Institute, and he started the Laboratory of Tropical Medicine. And then he also founded a Society of Exotic Pathology, over which he presided for many years. So, and he actually continued his malaria research even then, and he was doing some of this research in France, where we still had malaria then. And actually, what I thought was quite interesting, it was Alphonse Laveran that was first to express the view that the malaria parasites must be found outside the human body as a parasite of mosquitoes, which, as we know, was demonstrated by Ronald Ross, who was another parasitologist who won the Nobel Prize. I thought the timeline was a bit confusing, because Ronald Ross actually received his Nobel Prize for his work on malaria, by which he has shown how it enters the organism, and thereby has laid the foundation for successful research on this disease and methods in 1902, which was 5 years before Laveran's own Nobel. So it's a bit confusing, but I think it all kind of adds up, because he made his discovery in 1897, which is after Laveran published his work on malaria parasites actually causing malaria. So it did take a little bit of digging, but it did make sense eventually. Anyway, so I'm going to wrap up. So he was also interested in trypanosomes, and he published widely in that field. So he published work on veterinary trypanosomes, and actually Dixon mentioned one of those before. So trypanosomes that cause surine horses, Trypanosoma equiparum, but also those that cause Nagana in cattle. But he essentially was interested in all trypanosomes, those that infect birds and tortoises and frog and fish, and also human trypanosomes. So he's achieved a lot more really, high-level, interesting things, but I think I'm just going to skip over that. There were many, many achievements and prizes that he was also awarded. So in summary, really, Laveran, he was instrumental in establishing the field of study of pathogenic protozoa, which, as we know, we do that podcast on parasitic infections is really still very important, both in human and veterinary medicine. And so Alphonse Laveran died in 1922. So he wasn't actually all that old. And I thought he was an interesting man to learn more about. But from now on, if you're lucky enough to have the opportunity to analyse malaria blood fields, remember Alphonse Laveran when you do spot a gametocyte with a Laveran SPIP, because they are quite pretty. So that's my hero.
When I was at Rockefeller, Traeger used to sit around and tell stories about malaria. What else? And one of the stories that he loved telling was the one about how Laveran discovered the sperm of the sexual stage of Plasmodium falciparum. He collected the blood in the field from infected people and then bicycled them back to his laboratory at a hospital in North Africa. And on the way, the parasites transformed into the exflagellated form of, and by the time he got it under the microscope, he could see all these little worm-like projections off the surface of what looked like a microgametocyte, which turned out to be a microgametocyte. Cool. So he did a lot of fundamental work. He was amazing.
Yeah, he was pretty good. I enjoyed reading about him, and also actually his Nobel Prize acceptance speech. It was quite interesting too. There's a link in there. So if anyone is interested,
it's a very early Nobel, right? They only started in 1901.
That's right. That's right.
Yeah.
Cool. Yeah. Thanks, Dixon. Thank you, Christina.
Thank you. You're welcome.
Now, Daniel, I can't imagine you have another case. You must have run out, right?
So so this is going to be a challenging case, and I'm going to actually say this involves both a parasite and a virus. And I want people to try to put this together because I recently was reminded of this case. And so this is a middle-aged male that I actually I saw prior to the COVID-19 pandemic, right? And so he's referred to me because of eosinophilia, right? So he's got elevated eosinophils in his blood. So we got a little more of the history. What's the story with this gentleman? So this man's currently married. He's been married for a while. He's living here in the New York tri-state area with his wife. He went to see his primary care doctor, who did quote unquote routine blood work, and noticed that this gentleman had this elevated eosinophil count, this eosinophilia. So we get a little more history, which I always do. Where were you born? Where'd you grow up? Tell me kind of your story. And we find out that he had been in the military. He was a Marine. He served as a Marine, and he served as a Marine in Okinawa, Japan. Get a little more history about what happened while he was serving there. He was not a huge fan, I guess. He said he was pretty much bored when he was there, but he does describe assuaging his boredom. Would that be the right way to phrase that? By engaging paid sex workers while in Okinawa. But this was before he met his current wife. He's been monogamous with his current wife for many years. Now, a number of investigations are done. A test comes back showing serological evidence of a prior parasitic infection. He's treated with an anti-parasitic medicine. The eosinophilia resolves, but then the eosinophilia comes back. This is when he's referred to us. The blood work, which I order, is now showing evidence of a serological evidence of a prior viral infection that I think might explain why the eosinophilia returned after treatment. A little bit more information. We do a pretty thorough workup. The patient is HIV negative. He's not on any medications, and in general, he feels fine.
Daniel, what was the time between the eosinophilia leaving and coming back?
So it had been a couple months between like when it was resolved and when the primary care went to check it again.
And his wife is okay?
Wife reports she's fine. He actually tells us he feels fine too. It's just the doctor noticed this.
So this was an incidental finding, huh?
Yeah.
Yeah. I was wondering, you said he was married with monogamous with his current wife for many years. How many years are we, how long has it been since he's come back from Okinawa, essentially?
So it's been a number of years. Yeah.
10, 20,
yeah, 10.
5?
Let's say 10.
Let's say 10. Okay.
So 10 years, he comes back from Okinawa, then he gets married and he's here in the U.S. That's right. That's the timing.
Mm-hmm. And then, your wife makes you go see the doctor because, otherwise we would all just die. And doctor does some blood work. And now he's got this problem to contend with.
So he does not report any viral symptoms, right?
He says he feels fine.
Okay. Wow.
Was there any other blood works that were abnormal, or was it just the eosinophilia?
Just the eosinophilia.
The doctor that ordered the original tests, when it came back with eosinophilia, did he order? He didn't order any more blood tests.
So is
that correct?
This original doctor is the one that did the serological, test, saw that there was evidence of a prior parasitic infection, and treated him with an anti-parasitic.
This was in Okinawa?
No, that was here in the U.S. That was here in New York.
So you say serologic evidence, you mean an antibody test?
An antibody test, yeah. Antibody test came back positive, said, I know what this is. Take this medicine. You'll be all better. Check the blood work afterwards, quote unquote. The eosinophilia is gone. They're all better. And then a few months later, they check it. Oh, the eosinophils are back. What's going on?
And do we think that this parasite infection was acquired in Okinawa?
It's a good question. We don't know.
Do we? I had a question. I just forgot it. That's terrible. How did the doctor from the serological results decide it was a prior infection and not a recent infection or an ongoing infection?
It's a good question.
Right. So I have to think about that one.
Dixon, do you have any good questions?
I do, but I'd rather not ask them.
Okay.
No, but I don't want to lead the doctor into giving away what's there.
Yeah, I feel like there's enough information.
Okay. All right. So here's what you want to do, folks, listeners. You want to guess. Do educated guesses, of course. You send them to TWiP at microbe.tv with TWiP 247 case in the subject line. You got that? TWiP 247 case in the subject line, TWiP at microbe.tv. We will be accepting guesses until December 15th. You got a lot of time on this one because this episode we're recording on November 1st, but it's not going to publish until the 15th. So you have about a month to get your guesses in. TWiP at microbe.tv. Thank you, Daniel.
Oh, my pleasure.
And you can find the show notes for this episode from the 11:15 on at microbe.tv/TWiP. As I said, email is TWiP at microbe.tv. And if you enjoy these programs, we'd love to have your financial support, microbe.tv/contribute, or for November, December, January, parasiteswithoutborders.com, where they will double your donation. Daniel Griffin is at Columbia University Irving Medical Center, parasiteswithoutborders.com. Thank you, Daniel.
Thank you. And everyone, enjoy and be safe.
Dixon, Despommier, Trichinella.org, thelivingriver.org. Thank you, Dixon.
You're welcome, Vincent. And I echo Daniel's request. And make sure you vote also.
Christina Nowell is at Glasgow University. Thanks, Christina.
Well, thank you. It was a fun episode to be on. And good luck next week.
Yeah, we'll need it.
I'm Vincent Racaniello. You can find me at microbe.tv. I'd like to thank the American Society for Microbiology for their support of TWiP and Ronald Jenkins for the music. So, Daniel, I'll let you do the sign-off today, okay?
Excited.
You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon.
Another TWiP is parasitic.